webinar is part of a series of Living with Kidney Cancer webinars. This one is a special one for Kidney Cancer Awareness Week 2021. We're joined by Michelle Greenwood, who's mainly worked in oncology for the last 10 years. She was the first Macmillan Neuro-Oncology clinical nurse specialist, and also that role encompasses a lead teenage and young adult CNS role too. We're also joined by Daniel Richardson, who joined the team in 2020 to transition from his previous role in surgical urology to metastatic, and also Siobhan Smith, and she's been working in urology and uro-oncology since 2013. So I'd like to say welcome to them all. So if we think back to our previous webinars, we talk about earlier stages of kidney cancer. Today, we're focusing on treatments and care for those whose kidney cancer has spread when the kidney cancer has become metastatic. There can be a treatment plan, treatment and changes in treatment along the way. And the role of the specialist nurse is really important with these changes to support you during that. Daniel Richardson kindly wrote us a blog on a day in the life of a clinical nurse specialist. I would like to invite Daniel to join us just now to tell us a bit more about the role of the nurse specialist on a day-to-day basis.
My name is Daniel. I'm one of the uro-oncology CNSs over at St Bart's. I work with my colleagues Michelle and Siobhan, and I've been working here since June of last year. We cover urological cancers, so prostate, renal, kidney and testicular, with a big focus on metastatic patients as well. And as Mo has said before, I used to work in the surgical background. And I'm very thankful for Kidney Cancer UK to giving us the opportunity to promote our role, because we really are passionate about what we do here and for patient, experience and improvement. So if you haven't read the blog already, I advise you to definitely have a look at that, because it really gives a sort of a broad, review of what we do. So every Tuesday morning, we go to a routine meeting. So we have consultants, radiologists, pathologists, CNSs like myself, and we cover all of the Barts hospitals, including Homerton, and we discuss all of the urological cancer cases, and they're presented within this team. And we just ensure that the patient is on the correct pathway. And as a CNS, we sort of work as an advocate to make sure that our patients are having the correct treatment, the best possible treatment, and just to make sure that holistically all of their needs are focused on, and just making sure that they're on the right pathway basically. And then after that, I go to a testicular and prostate cancer clinic. That's in the morning, and then once that's done, I start the kidney cancer clinic with Professor Powers, who's one of the leading kidney cancer doctors in the UK. And here we meet patients after review with the doctor, and we perform what's called a holistic needs assessment, which basically focuses on the physical, emotional, psychological, financial. So every aspect of that person we take into consideration, and we try and sort of map out ways that we can support them through referrals to Macmillan or Maggie's. And in particular with kidney cancer, we are very passionate about referring to Kidney Cancer UK for their counselling and psychological support. And they also provide grants on a case-by-case basis. So we really are very happy and fortunate to be very close with Kidney Cancer UK because of the support they offer to our patients. We also make an emphasis on making sure that the patient knows that they can contact us if they've got any concerns or questions. So we give them our number and our email address, and they're aware that they can just let us know if they've got any questions about their treatment or diagnosis, because we appreciate it can be quite difficult to discuss these things with the doctor when you're having clinics, certain intervals throughout a time frame, and also access to the GP is quite difficult, especially with the COVID pandemic. We also, so that's kind of basically the things that we do with that. We also do first cycle counselling when patients are started on specific treatments in kidney cancer, so the TKIs. We make sure that the patient understands the role of the medication that they're taking, and put an emphasis on making sure that the patient informs their CNS of the side effects, because we don't want that to escalate, any further. So we always make sure that the patient is aware that if they've got any concerns regarding side effects, they let us know sooner rather than later so that we can help to treat those. And that's about it. And then the following day, I have a lot of paperwork to do. So a lot of scanning, faxing, referrals to, district nurses, etc. So that takes up most of my days after clinic. But it's a very rewarding job. And all of us here are really happy to be doing what we're doing for our wonderful patients. And thanks again to Kidney Cancer UK for all that you do. We really do appreciate it.
Thank you very much, Daniel. That was really enlightening. I loved reading your blog. It gave us a great deal of insight into your day. So what we're going to do now is go on to the main talk. So here is the managing treatment side effects, and it's going to be presented by all of the team.
Hi, good afternoon, and thank you for joining us today. As you already know, I'm Shiv, my colleague Michelle's online, and obviously you just heard Daniel speaking. So we're talking about when you start treatment, and on the next slide, so targeted or immunotherapies are given to people who unfortunately have had kidney cancer which has spread outside of the kidney into other areas in the body. So kidney cancer or any cancer will spread in the lymphatic system, and we know about kidney cancer generally goes to bone, liver, lungs and brain as primary areas. So how does the treatment work? When we're looking at immunotherapy, obviously we would want the immune system to reactivate, like the police really, to go around and fight these cancer cells. So those cells are empowered by the immunotherapy products that we use, and they literally run around the body and help our T cells recognize the cancer cells and attack them and fight them off. And the theory is obviously that our bodies can then, free us of these cancer cells. And clearly it's not as simple as that, but this is a simplistic way of trying to understand it, and was the best way that I learned to understand it throughout my training. So targeted therapies, or TKIs, tyrokinase inhibitors, regulate how the cells grow and divide. So they block proteins in our body from sending signals within the cancer cells, and hopefully we're going to cause their death. So basically that is to stop the cancer cells developing new blood vessels, which we call angiogenesis. Side effects that you need to be aware of, obviously blood pressure is a big issue for our patients, especially on the TKIs. So this is on our next slide. Many of the TKIs obviously cause high blood pressure, which you know as hypertension, and we like to make sure that this is well controlled before you start a TKI. I think the slides are stuck on my view here, so I'm just on the blood pressure slide, please. Thank you, Mo. So we like our patients to have their blood pressure checked in the clinic, and we like to make sure that they're safe to proceed with any kind of targeted therapy. If obviously there are any issues with the blood pressure, then clearly that would need to be treated before anyone starts on any kind of therapy, because that would be dangerous and we don't want to take any risks with our VIP patients. So we monitor blood pressure regularly, and I know that Michelle's very keen on telling all of our patients that they must have blood pressure machines at home, and obviously the ones that you use on your upper arm are better than the ones that you use on your wrist, because unfortunately the wrist devices are not as accurate, though they may well be cheaper. Now, some of our companies who provide TKIs were very kind and give out support packs and blood pressure machines, but unfortunately other companies don't offer that. So these machines are generally about £20, and if there's any issues we can always ask our lovely friends over at Kidney Cancer UK or perhaps over at Macmillan to assist with funding for these. Our next main thing is hand and foot issues. So on the next slide, we're talking about sore mouths, sore hands, and sore feet. So little tips that we obviously mention in clinic are making sure that your hands and feet are well looked after before you start any treatments, that your mouth is clean and you wash it with water, rinse it around, do a little bit of gargling, keep your teeth nice and clean and free of any debris, obviously using gentle toothbrushes if your mouth is especially sore. Now, I know that there were some questions that already came through to us about certain products. We generally would avoid anything that has alcohol in it, because some of those mouthwash products or toothpaste are really, especially, quite harsh. And when you've got a very sore mouth or a start of a sore mouth, that can be really debilitating. So clearly we want you to keep an eye on your mouth, keep an eye on your hands and your feet, moisturize them, make sure when you're washing that you dry your hands and feet especially well, and that, as Daniel said, you're reporting any issues early. So if you have a sore mouth, you let your clinical team know about it. If your hands or your feet are getting a bit red and a bit sore, or you've got a crack to the skin, please let us know, because it's better that you stop these therapies even for a couple of days than you end up with a hole in your hands and you're stopping the treatment full stop. So please report things early. Most people have the oncology hotlines for many trusts, or you should have regular access to specialist nurses. So obviously avoiding things that are extreme, hot foods, spicy, ice, anything, super cold or super hot, could really sting in the mouth. So please be careful with those things. On our next slide, we're talking about altered tastes. Now, some people feel that they have a metallic-y taste. Food that they previously enjoyed was no longer enjoyable, or they can have a especially dry mouth. Obviously, changing foods that you previously liked, if you don't like them, there's no point in eating them, is there? Obviously, if you're limiting your diet, then you need to add something new. So experiment with it. Try something new. Maybe you might enjoy that pineapple, and that might clear that metallic-y taste from your mouth. I'm going to hand over to my colleague Michelle. It's going to carry on with the next slide on fatigue. Thank you.
Hi, I'm Michelle. Thanks for having us here today. We're really pleased to be here. So we're talking about fatigue, and fatigue is a really difficult side effect to manage of the targeted therapies, and probably the ones that patients struggle with the most. As you can see on the slide, it says that 9 out of 10 patients on treatment get fatigue, so that's a high number. So sometimes little things help. So having a bit of a routine, making sure that you actually get up and get dressed every day, which sounds like standard to most people, but actually can be really difficult if you just haven't got the energy or the motivation and no kind of reason, as most of us have had in the last year with COVID, no reason to go out. But actually getting up and having your shower and getting dressed and going out, and just having some regular gentle exercise, including just walking in the park, is really good to try and help with the fatigue. And if you find things to do like hobbies, then I think that really helps keep your mind active and keep you less fatigued. Regular breaks when you're doing things, so if you're at work, having little short breaks to kind of like get up, walk around, do something a little bit different, can help too. Eating well is really important, so having a varied and balanced diet of different foods and different food groups is really good for making sure you stay healthy as well, and making sure that you sleep well at night. And sometimes that can be really tricky, but things like having naps in the day can make your insomnia worse. So if you can manage to keep yourself busy all day and doing things, then you might find that you sleep better at night. On the next slide, I'm just going to talk about blood abnormalities. So with a lot of these treatments, immunotherapies and the targeted therapies, it's really important that you're attending your clinic appointments for regular monitoring. So, blood abnormalities is difficult for you guys to actually know that there is a problem sometimes, but we will check things each time you come. So things like liver toxicities, which some of the targeted therapies can cause, and thyroid functions, which actually almost all of the treatments can cause. And obviously we want to know that your kidney's working fine and that your creatinine levels are not too high, or that you're not becoming anemic. So they're really important things for making you feel well, and also for keeping you well and keeping you on your treatments. So the next slide's a little bit busy. it's talking about immunotherapy side effects, which are a little bit more tricky and a little bit less standard than the targeted therapy side effects. So with targeted therapies, most of them have the same side effects or similar, and we can kind of almost predict what they're going to be. With immunotherapy, some people find they have no side effects at all, which is great. But sometimes you can get quite severe side effects, like some encephalitis in the brain, or some, problems with your lung, the pneumonitis, or you can get some really bad colitis. And if those things happen, they tend to be a little bit catastrophic. So, again, that's the importance of reporting issues early. So you might think that a small amount of diarrhea is not too bad, but actually that can escalate quite quickly. And if we can get on top of that at the early stages, then we can stop things from becoming too bad and hopefully keep you on your treatments. So I think on the next slide, I've said some of that, just saying that some people have no side effects, and some people find that if they do get side effects, they can start at around 3 weeks after beginning the treatment. And like I said, it is quite rare that the side effects are debilitating, but when they are debilitating, it's obviously quite serious to the patient involved. I think because we are, poking your immune system to attack the cancer cells, we can sometimes make your immune system a little bit overexcited, if you like, and it can start attacking things that we don't want it to attack. And, sometimes skin rashes are a big problem too. So keeping things, being aware and reporting things early is really important to, and I think that the CNS role here is really invaluable. And I hope that you'll have great CNSs, because we feel that that's the best way to keep you on these treatments, keep you healthy, keep you well, and keep you living life to the full for as long as possible. So the next slide talks about trials, which I think has come up in the questions as well. So, we're quite fortunate at Barts to work with Professor Powers, who is extremely trials focused. He really has been doing trials for a long time. And I worked with him in the early days, about 8 years ago, when there were very little treatments for metastatic kidney cancer. And through all of these trials that, we are participating in, we've now got quite a lot of lines of treatment. It's about working out where they fit. So they've got lots of lines of treatment now, but they haven't quite got to the point where they know what goes best where, or what's going to work for who. So this slide just is a bit busy again, but it talks about some of the trials where they combine the immunotherapies with the targeted therapies. And I think that they do feel that because sometimes when you're on one treatment or the other, you get a mixed response. So some areas of disease respond to treatment and others don't, they may grow. So I think the feeling is that if you target it from different aspects, like the immunotherapy targeting your immune system and the targeted therapies targeting the growth pathways, then you could hopefully stop that mixed responses and get good responses. But I think the difficulty with some of these trials is that the side effect profile is quite harsh, and it's about trying to get that balance of quality of life versus treatment. I'm going to hand over to Daniel, who's going to go through some top tips with you.
So these are some of the top tips that we sort of advocate our patients to kind of follow once, when they're on treatment, So the main thing is, as Shiv has said, avoid alcohol and harsh mouthwashes. So there's a lot of gentle mouthwashes that are available on the market, and, they're very, they're good at what they do. They'll, so, stick with them. They'll still help with the bad breath as well, that we all have. So they'll be fine. And try foods that you may think that you don't like. So you might be surprised there's certain foods that, you really do tolerate quite well. There might be something that you always thought that you disliked eating, but then, you end up trying it and you think it's, the best thing since sliced bread. Use moisturizer even when your skin looks, intact. So especially in colder weather and especially now with COVID, when we're all using a lot of alcohol gel on our hands, it's really important to keep your hands, moisturized and stop it from, breaking down. And also it's really important to monitor your blood pressure at least once a week. And we often tell our patients to, keep a diary at home of their blood pressure reading, so that when they come back to see their clinician or their CNS, they can just let us know of their blood pressure readings. and following on from that, making sure that, you know, our patients are aware that they report any side effects sooner rather than later. So, you know, if the blood pressure does start to raise, you know, it's best to just let us know when that does happen, so that we can, you know, find steps to help support that. So the next slide is over to you guys. So we really want to know any tips that you might have found helpful with yourself, because we're always looking for ways to, you know, from patient experience and patient advice on what we can pass on to our patients. And obviously, you know, the people listening in this forum, it'd be great to share tips and advice. But thank you very much for listening to our presentation. And we really hope you have some questions, and we'll be happy to answer them.
Thank you very much, guys. That was a really great talk, particularly the hints and tips really for managing these side effects and your role as well. So fantastic, Daniel, Michelle and Shiv, really good insight. So I have a list of questions here, which I would love to share with you. The first, some of them have already been covered. What are the advantages or disadvantages of joining a trial? Does someone want to take that?
Hi, so it's Michelle. I think what we had was, I think, so to me, I feel quite passionate about the trials actually, and that's probably because I've worked as a trials nurse, you know, in kidney cancer trials. And when I started working with Tom doing that, I think that there were very few treatments. I think, you know, we'd had some immunotherapy, you know, like IL-2s, and then when they developed sunitinib, and there was very little else. And I think that all the trials that people participated in, on the whole, they were kind of like, there were very few trials that were not successful. And all of those trials have helped to develop further treatments. And that's why today we have, you know, multiple lines of treatment. And I think that they give people the opportunity to have extra treatment and have given people extra time. And, you know, you're quite well monitored, the side effects are well controlled. You know, if there are issues, then you would, you know, manage that quite tightly. So, you know, if you have metastatic kidney cancer, you wouldn't be given a placebo trial alone. You would always be having some kind of active agent. So on the slide where it showed about the trials, there's a couple of trials there that have got, you know, like immunotherapy plus or minus a TKI, because they're trying to work out if that's feasible to give. And that trial is a TKI plus immunotherapy, sort of plus or minus a placebo or TKI. So that is okay, because you're still getting the immunotherapy regardless of whether you get the TKI or not. So I think that, you know, ethically we wouldn't be able to have placebo only trials for metastatic kidney cancer patients, because they would have to have some form of treatment, and you would never be able to not give that.
Thank you. That makes a lot of sense. The next question is, what are the basic differences between immunotherapy and targeted therapy? And I think that was covered earlier on. But another part of this is, why are some people prescribed just one of these therapies and others a combination of the two? Who would like to take that part of the question?
I think that we tried to cover some of that when I was saying about the trials, because what they're trying to work out is that how do you get over that mixed response to a treatment where you've got areas of disease that respond, you know, if someone's on a TKI, sometimes a scan might come back as showing mixed response. Okay. And what you're trying to do is target all areas and avoid that mixed response. You want a good response to the treatment.
I think as well it's fitness, isn't it, Michelle? So, you know, somebody's performance status, what treatments they've had previously. And, you know, the treatment trials that we're doing here are, you know, phase 3, so they're nearly standard of care. Sorry to interrupt you.
The next question is about COVID. Do you feel that that COVID has changed availability of therapies, and why?
Yeah, it's difficult to answer. Obviously, generally speaking, we can't answer that. But in terms of site-specific here at St Bart's Hospital, you know, we're still continuing with trials and we're still continuing with treatment. I mean, we're quite fortunate here that at St Bart's is a sort of a COVID-free, you know, zone as such. So patients are still able to have their treatment still, and, you know, their targeted therapies. So, yeah.
Yeah, no, that makes sense. And obviously, COVID is a big topic at the moment. So the next question is about that. Do treatments make patients more vulnerable to infection? Should they shield during the pandemic? Should they accept an invitation to COVID vaccination?
So I think there's two parts to that question. And we did, in the first wave, advise people who were on targeted therapies and immunotherapies to shield. And I think that's because obviously you can sometimes TKIs, not very often, but they can lower the immune system. And we don't really know enough about COVID and how it would affect somebody who's on a TKI, I don't believe. I mean, I think now there's more evidence than then, and perhaps it's not as bad as we thought. And there's certainly no reason why treatments should stop. Treatments should definitely continue if possible. But the new guidelines are that everyone should have the COVID vaccine if they're on a TKI or immunotherapy.
And if anybody wanted to read those guidelines, that's the ESMO guidelines, which are the European Society of Oncology.
And I think that if anything out, just speak to your clinician, that they'll be able to give you that advice regarding the vaccine.
Another question I have here is why do treatment doses and cycles vary? Protocols seem to predominantly start with a higher dose and lower if side effects cannot be successfully managed. Is there a correlation between the intensity of side effects and the effectiveness of the cancer cell viability?
Again, a lot of that is based on the trials. So the schedules are basically, when a drug gets a license, it will get the license from the evidence of the trial that it's been a part of. And so the schemes, the dosing regimes will be kind of like dictated by that. And, I think that, there is a feeling that if you do get some side effects on a TKI, it is working better. It's a bit anecdotal though. There's no kind of real hard evidence that that's the case. So like if you're on axitinib and you get a higher blood pressure, that is said to be an indicator that it's working quite well. But that's not to say that everybody who doesn't have a high blood pressure doesn't kind of get a good response. I think it's difficult because once the drug's licensed and the clinician has experience of using it, they can adjust how they are dosing it and how they are saying like, maybe it's supposed to be 4 weeks on and 2 weeks off, but actually we might say to somebody who's struggling with side effects, have 2 weeks on and 1 week off, because you're still having 4 weeks in a 6 week period. And that is trying to be, adjust the treatment for the patient to make sure that their quality of life is good. I think that the feeling is that you should start high on the dosing. So you should start everybody on the maximum dose because you don't want to underdose people. And I think that you'll find that if everybody was to start on a lower dose, what would happen is that the clinicians would never increase the dose on the whole. So that is why you would always start at the higher dose and bring it down according to the needs of the patient who's having it.
That makes sense, thanks. And some of the other questions I think have already been covered. So why would a patient with advanced kidney cancer that spread to the lung go with a clinical trial treatment rather than a drug that's already been used a lot? Is anybody anything to add to that, or do you think it was covered by the first question?
I think that we just would want to add that if somebody's having something on trial, then that's like an extra line of therapy as a generalisation. So, you can still have perhaps that same drug which you had on a trial as another line at a later point in time. So it's about being clear when you're talking about a trial, like Michelle was just saying, because these are phase 3 studies which are nearly standard of care and not something that's experimental, and that's sometimes missed.
Yeah, absolutely. And someone's also asked, what does it mean by a clinical trial? Does that mean it's not really been used much? But I think we've probably talked about the nature of clinical trials at the beginning.
I think it varies, Mo, actually. So when I was a research nurse, we were doing some phase 1 trials, but they are very, very tight and very specific, and they are mostly about trying to find the right doses of the drug. So the drug is actually already quite established, but it's about finding the dose and the regime.
Yeah, in healthy subjects before they go on to the different phases of the trial. Absolutely. Someone's just asking, they live in Scunthorpe and have never been offered a trial. It's quite difficult, that, isn't it? Because it may be that the person's just not suitable for the trial. If you get anything to add about that?
I think it is difficult, and I think that a lot of centres, because of logistics and staffing and, you know, all of the kind of like governance that goes with a trial, some centres just aren't able to offer them. But mostly those centres would know about trials that are taking place locally and refer onwards. But, you know, it depends really on the clinician that you're seeing and whether they have that knowledge. But we certainly get referred people and self-referrals as well at Bart's to, you know, to come and undertake a trial. And because they've been referred for a trial, it doesn't mean necessarily that someone's going to actually get onto a trial, because as Shiv said, you need to have the fitness, you need to pass the eligibility screening. You know, depending on what trial it is, each trial will have its own eligibility criteria, and you have to fit that, otherwise you won't get on that trial.
Absolutely, the criteria is very strict for a reason, isn't it? So that the research can be carried out fairly, but it is a difficult ethical situation. Someone has also asked, how would a treatment plan change if they've been told that the cell type is aggressive?
So I think, you know, obviously you'd still be treating it as a kidney cancer, even if it was in the lung. I take it this is the question about the lung, isn't it? Where, yeah. So you'd still treat it as a kidney cancer, is the bottom line. And, you know, you would have whatever your clinician thinks is the best treatment for your kidney cancer.
Someone's commented, you know, when their treatment changed, it wasn't necessarily the one that they felt was relevant to them, but more about what was the next one on the list. So we know that there are different lines of therapy, which I've not really mentioned. There's first line, second line, third line, approved by NICE and up in Scotland in SMC. So
that is true. There are, I think they do have more lines of treatment now than we ever had before, but they still, like I said, they still haven't worked out what's going to work best for each person, and that should really be the direction. And I've spoken to Tom Powers about this before. That I feel should be the direction of where kidney cancer goes next, because we now have a lot of treatments. But we need to know, how do we know what's going to work best for who and what lines they should all have, you know, and some of it's very prescribed by NICE, but yeah, it's difficult.
That's very true. We have European guidelines, but no UK-wide guidelines at the moment. So NICE and SMC, you know, approve drugs at certain stages. Certainly in my time with kidney cancer UK and kidney cancer Scotland, the landscape has changed phenomenally, if that's the right word. So it's been a bit more hopeful for people. Someone asks how many trials you can do as a patient. That's an interesting question.
There's no limit as far as I'm aware, as long as you fit the criteria. So some trials will say you can only have had certain amount of treatments before. So, you know, it really does depend on what the eligibility criteria says. Yes,
absolutely. Someone's asked a question about sunitinib. You know, is there any data about how long it keeps working for, and what's if there's a longest time that it's worked for in your knowledge?
I think that's a very controversial question.
Yeah.
But, I know Michelle's got a number of patients been on Sutent for a long while.
Yeah. I think, you know, it really does vary. So the average, as you know, is about 11 months. But like Shiv said, we've got some patients who've been on it for maybe 5 years, and other patients who maybe have been on it for 3 or 4 months. So it really does just depend on the patient and how well they respond to that treatment. And again, that's why I think it's so important to get to the bottom of who's going to respond to what, so that we're giving you the best treatment from the start. But, you know, that's still a way off. Yeah, I feel.
Yeah, that precision medicine that we all hear about, it sounds as if it's just something quite magical. We'd love to know about. Someone was saying they're on 400 milligrams but had some bad side effects and been in 200 milligrams for over a year. How are treatment outcomes measured for these therapies, and is it dependent on the tumour grading?
Well, as far as I'm aware, it's just CT scans, the clinical picture. So how does the patient look when they're in front of you, even if the CT scan says that everything's okay.
Absolutely.
And, you know, blood tests.
And quality of life as well. More and more quality of life measures are being used to looking at
Most definitely.
toxicity. Someone had asked about could there be potential for patients to be invited to the multidisciplinary team meetings. But again, as Shiv has said, it's quite a long list of patients to be talked.
So there's usually around 70 patients on a urology MDT. Correct me if I'm wrong, Shiv. And I think you couldn't have 70 patients in the room with you. So that would be tricky. But that is the role of the CNS, as Daniel said. The CNS is there to advocate for the patient at the MDT. That's why if we know the patients, then we can say, you know, we can speak up at the MDT and say, well, actually, that's not really what the patient wants. Maybe they didn't want their kidney removed or something like that. Do you know what I mean? So
yeah, and that is the next question. Yeah, it's just how are the patients' views and treatment preferences communicated, and that is via the specialist nurse. So having a specialist nurse or a team of specialist nurses is ideal to do that. So just remembering to make your wishes known there.
But I think it's very important to say that you have the discussion with your clinician when you come to the clinic, because I'm quite mindful, and I don't know, I didn't see the reply to that, sorry, if the person's maybe private or if there was other reasons to why they hadn't met a CNS, because that can sometimes be the case. We also know that sometimes people say they've never met any of us, and then one of us will come in the room and they'll be like, oh, hi, I know you.
Yeah, I know who you are.
Yeah, you're nurses, hi. And then it'll be, you know, flowing, and they know that they can contact you and things like that. And, you know, a lot of it is when you are in distress, it's just so awful, isn't it? You can't even think straight. You, like, 10 people are talking at me. What did they say to me? They've given me this pamphlet. I've put it in a dustbin. So, you know, call the switchboard, ask to speak to, you know, whoever's caring for you, get the secretary, find out if there's a nurse, because even at private practice, they do generally have specialist nurses working there, or an oncology nurse that you can get support from.
I think that's really important. And again, that answers, you know, your doctor will advocate for you if there isn't a clinical nurse specialist there. But we know now that there are much more clinical nurse specialists around. It's been a bit difficult in some areas because of COVID, so some nurses have been redeployed, but that's mainly on the surgical side from what I've heard.
I'm smiling because I went to ITU for 5 weeks and dumped all of my patients on my lovely colleague Michelle, because Daniel wasn't even in our team then. So, you know, I just saw that question half pop on the screen, and I would say it's been difficult. But, you know, as I said earlier on, I think it was a chat, most people have hotline numbers. You should have access to your teams. So, you know, go through the switchboard if you have to. Be the, you know, persistent patient, or whatever you want to label yourself as, because this is your healthcare. We are here to work for you, and we do our very best. And, you know, you should have access to that service.
Quite lucky at Bart's as well, because our associate director of nursing, who was doing some of the redeployment last year, was keen. He's an ex-CNS himself, so I think he understands the role a lot more. And he was quite keen for someone to stay and, you know, make sure that the cancer patients were being monitored and, you know, there to answer questions. So he was happy for Shiv to just go and for me to stay. And although it was very difficult, that meant that there was still somebody in the post to help manage the side effects and try and keep these people, you know, these patients out of hospital.
Yeah, I think that's really important, Michelle. And that was another question. Well, what do you do if there isn't, you know, if you want to get in touch with the CNS quickly, or there isn't a CNS, it's just going through the telephone line, that number that they've been given, or going through the hospital switchboard that way as well. And someone has also asked about how has COVID affected, which I've probably answered, the clinical nurse specialist working patterns. And that's difficult to answer because we can't talk about every region, and Shiv has said, you know, at one point she was redeployed, so Michelle and Dan were taking over. Have you got anything else to add about that?
As a generalisation, specialist nurses work office hours. Obviously, you might work longer on a clinical day, perhaps, But, you know, that it's not a 24-hour service. We don't work weekends. And sometimes, you know, patients expect us to, but, you know, actually we can't work that many hours in a day. So it is tricky, like you say, with redeployment as well.
Yeah, absolutely. And someone's asked a brief question about blood tests. You know, she understands the reason for these to check thyroid, kidney and liver, etc. But can they tell if cancer is progressing or regressing from your blood test?
I think it forms part of the overall clinical picture, actually. So taken alone, you know, maybe they might not be the whole story. But if someone comes in and they look terrible and their bloods are terrible, and then maybe the scan is, you might want to scan them, and then maybe the scan's not so great, or, you know, or if someone's bloods are not great but they look great and they feel great, then you have to kind of try and work through what's going on. You can't, I don't think you can just say, oh, your bloods are terrible, you know, this is really bad for you type thing.
Yeah, no, I can understand that. Someone's also asked, does anyone with metastatic disease ever get to the point where they're deemed to be in remission and can stop treatment and just be under surveillance? That's an interesting question.
It may depend on how much disease they had to start with, I feel. If they only had a small area of disease, or, you know, very small volume disease, and they have a good response to a TKI or immunotherapy, and it kind of shrinks down to almost nothing and stays like that for a while, then that would probably be the best scenario that I think I've seen and you could hope for. But tends to be, obviously, if there's more disease, that's harder to achieve.
Yeah.
Some people that have early Mets as well can have maybe cryotherapy or solitary lesion removed. Maybe it might be the testicle or the uvula, or, you know, somewhere, you know, I'm talking about the back of the throat there. That's rare areas that we've seen it, because these things sort of pop up all over. So it's just reporting things early and stuff if you're concerned, I think. But it's a bit of a tricky question to answer. Maybe they need to go back to their team as well and ask that question.
It is a tricky one, and we certainly hear of some people who do well, not quite remission, but certainly do well. So why don't we stop the question and answers just now? Thank you everyone for contributing to that, and thank you guys. We'll put you on the spot there. You did really, really, really well, and I think it's been a fantastic discussion. What we're going to do just now is I'm going to invite a couple of people on as panellists as well, who are going to share a little bit about their journey with side effects. This is the interactive part of this webinar. So we're joined with Darren and Jenny, who are going to just briefly tell us a little bit about themselves. So Jenny, you've had experience of quite a few treatments now, haven't you?
Yes, I have. I'm on 4 treatments. So I'm on my 4th treatment now. So I've had immunotherapy, and now I'm on targeted therapy. So yes, I've gone through quite a bit. I've done the research, gone through the PRISM study as well. So I've had a mixture of side effects. Yeah. Do you want me to?
Yeah, if you could tell us a bit more about what was tolerable and what did you need help with when it comes to side effects, if that's all right.
So when I was on the immunotherapy, I can never say the names, so ipilimumab and nivolumab. Okay, so do correct me. I just turn blind to those words now. So basically I was fine, I was brilliant, and I thought, oh wow, this thing must be working. But then a few months later I had a rash which came up, and it did actually lead me to going into hospital. So originally they just thought it was just sort of like an allergic reaction, and I had possible sepsis and pneumonia. So I was taken off of that drug. So it was just, you know, so I wasn't on that drug for very long, but the rash came up and they sort of gave me an antihistamine and some cream, but literally the next day I had to go in because it was getting worse. And then I was in A&E. So that was something I think some people need to be mindful of, especially for me, because I suffer with eczema anyway. So I wasn't sure, you know, whether it was just a food reaction or anything like that. So that was one of the reactions I had with the medication that I told you about. And then I was on adalimumab, and axintinib. I can never say the names, okay? So again, I had no skin reactions, but what I did have was like my skin was sort of patches. So there was lighter areas of my skin and darker patches and everything like that. But what was really bad was my feet. It wasn't blistered, but it was actually walking on my feet. So after a while, I just couldn't walk. It was painful, but I persevered because I didn't let it stop me. But I have to say that when I did stop, it was very painful for me. So that was one of the things that I found very struggling, to be honest with you, being such an active person that I am. I was then on, with the lockdown that we had, I was just only on the axidinib, and I then noticed that I had diarrhea a lot, which was really, really bad. And my hair was just starting to be very brittle and was starting to fall out, and just really bad stomach cramps. So that was another problem I had with this medication, just with it on its own and not with the Avlumab or whatever, you know. No, yes, it was really harsh on me. So I found that quite hard when I had a lot of the diarrhea. Luckily for me, in a way, it was always in the evenings. So I would be going for about 3 hours in the evening, then it would stop and it would ease. So again, it was like, you know, some of the things that were suggested, certain foods that you eat, but I wasn't in the mood for eating when this was happening. And the medication I'm on now is the everolimus and the letnavitnib. And I started off on a very high dose, and that was just awful for me. Again, it was the diarrhea. I had really bad stomach cramps. I didn't want to eat. And so I'm sweating now, and I'd lost appetite, and I had these blisters on my hand. It was really weird. I had these blisters, and it just they weren't sore, but they were very sensitive, and they were just, it was quite gross. And again, so it just sort of like, yeah, so those were the things that happened to me. But I think it was the diarrhea, the walking, the cramps in the stomach, and not being able to eat because I'm a foodie, really kind of impacted me in many ways. So it was like some of the things that you guys suggested, I did, you know, toothpaste. Oh, and at the moment now I've got like my gums. So like you were saying, a lighter brush. My consultant said to use kids' toothpaste as well. So that's what I've been doing. But one of the issues I am having, and it's been throughout all the medication, is sleep.
Yeah.
Everything, tried everything. So sleeping is a problem for me.
That's a difficult one. No, thank you so much, Jenny. That it was really extensive, which is what we really needed to hear, because you've been on these different lines of treatment. So you've had all the different side effects. So I know people will really benefit from that. Could we go over to Darren, who's probably nodding his head there because he knows, and I know that it's you know, it's a similar story with the side effects, Darren, isn't it?
Oh my God, yeah.
Again, over to you, where, you know, just tell us a little bit about, you know, what's been tolerable and what's been not so tolerable, and what has helped with you.
Yeah, no problem at all. I'm Darren Roberts. I'm 53 years old. I have metastatic cancer. I'm being treated at the Marsden. James Larkin is my prof, and Nikki Hunter is my CNS. I mean, I've listed. Obviously, I had the full nephrectomy when they found the tumor. It started off with bladder cancer, then it went on to they found the tumor, blah, blah, blah. First round of immunotherapy, they put me on ipilimumab and nivolumab. See, I know these words now, I've become an expert. Literally one cycle, and I got an aseptic meningitis with photophobia. So I literally woke up one morning, I couldn't see anything. So they rushed me in, basically kept an eye on me, took me straight off the treatment, knocked out my thyroid as well. Then I went on to cabozantinib, the TKI, sent my hair white. I mean, my hair went absolutely white. It was over December, which was quite strange. People thought I'd done it on purpose to look like Father Christmas, because I'd had the tash as well. Diarrhea, sore feet, like Jennifer says, really bad feet, just incredibly bad feet, high blood pressure. But we decided at the time to let me fluctuate the toxicity. So I was fluctuating between 60, 40, 60, 40, which I was finding that I could tolerate more. The diarrhea didn't go away, but it helped me with the sore feet and the hands, obviously the bleeding gums, the teeth. Again, like Jennifer said, I changed my toothpaste to kids' toothpaste, soft toothbrush. And I was just always just looking after my feet, putting cream on my feet all the time. Cabozantinib stopped working after about 6 months. Then we went back onto another immunotherapy, which was pembrolizumab and axitinib. I can pronounce the words. It wasn't the pembro that was causing the problems with this. The side effect that I had really bad was with the axitinib, which I'm currently on. Weight loss, my God, I lost 25 kilos in 4 months due to diarrhea. I mean, we were really worried at the beginning of it if it was like a sort of colitis thing brought on by the TKI. But you know, to manage that at this point, because I couldn't tolerate any food, it was just ridiculous. I was just eating something and it was just coming out of me. I got a dietitian involved privately. I know that's a bit of a luxury, but I work at a company where everybody sort of put in some money to be able for me to have that. And she encouraged me then to start keeping a food diary. It's the one thing out of all of this. I mean, the one side effect out of all the drugs that I've been on is diarrhea. The rest of it I kind of manage because it's a case of just deal with it. You know, they're going to throw the bus at you. You take it because you want to live longer. So you just go with whatever they give you. But the diarrhea is so debilitating, and it gets to such a point where you're just like, I can't go out. I've got to take loperamide with me everywhere. It's just ridiculous. So keeping a food diary allowed me to sort of see the foods that triggered off the symptoms of the colitis, or the drug-induced colitis as we thought it was. And then I was able to sort of say, well, look, I can eat that, I can't eat this, this will send me over the edge, that won't send me over the edge. So I found that really, really important. And obviously then I started to put a bit of weight back on, and I was managing things a lot better. The unfortunate thing about me is I'm at the business end now of my treatment. I went in for a scan a month ago and was told that the immunotherapy that I'm on, the pembro and the axitinib, is working for me. I have no mets anywhere in my body, apart from in the center of my chest. I have lymph nodes, 2 clusters of lymph nodes that unfortunately aren't responding to the immunotherapy. So I've had to come off that. I'm now in the Marsden in Sutton having some palliative radiotherapy into my chest, to hopefully kick back the lymph nodes so that the immunotherapy might have a chance to work. We want to see if that works. So if we kick it back, bring everything back to a level, hopefully, that I can manage, and then I go back on the immunotherapy on the 15th. But yeah, I've been on, I mean, I've like Jennifer, I've been on a lot of different kinds of drugs, but the common denominator for me is fatigue and diarrhea. And yeah, I just encourage people to look at what you're eating. You know, stop eating the foods that you know are going to trigger the diarrhea. I mean, I've got diarrhea all the time. So, you know, there's different levels of it. There's the watery stuff, which gets dangerous, but then there's the other, God, it's 4 o'clock in the afternoon. I'm talking about my poo, outrageous. But you know, you just manage it, you know, managing it through food diaries, through, you know, loperamide. I don't dose it. I mean, I was popping loperamide like Smarties at one point, but now I don't have to do that because of, you know, we're watching what I'm eating and just making sure that we're keeping a close eye on it. So thank you.
Thank you, Darren. I know a lot of this already from our conversations, and I just knew you would be such a valuable, you know, addition to this talk. And these are things that the team talks about, you know, fatigue. Jenny talked about, you know, the problems with her feet, just in the diarrhea, which is sounds small, but actually it can have quite an impact on going out the house and things like that. Thank you again for joining us, Darren and Jenny. You can stay on the screen just now if you want. So this is very interactive at the moment. So there's a couple of people who've got their hands up. So we've got Eleanor, who's going to join us just now. Okay. Hello, Ellie. How are you doing today?
I'm all right, thanks.
So this has been quite a webinar, hasn't it? What have you got to offer, hints and tips and things about your side effects you've had? Because you've been on a number of treatments as well, haven't you?
Yeah, I started on Bartholomew in 2017 after it found that it had metastasized to both lungs. The only side effects I was getting was high blood pressure, underactive thyroid, and as Darren said, diarrhea. Diarrhea was horrific. Like, I couldn't go out. I couldn't move from the living room. I'm lucky that my toilet is to the left of my living room at home, because same again, just the thought of having to leave the house terrified me. I worked night shift as a support worker for the homeless in Inverness, and I ended up taking the Bartholomew at night, so that if I did get diarrhea, I was at work, because I worked in an office, basically keeping an eye on clients who lived there. So it was easy enough for me to get the toilet. I didn't take it in the morning because I felt as if I couldn't sleep. And then obviously with the diarrhea, that was keeping me awake as well. So for me, it worked taking it at night. And as well as using loperamide, I get codeine from the doctor for the diarrhea. I wouldn't say it worked great, because, and as Darren said, no matter what I ate, I lost weight rapid. I would lose 3-4 pounds every fortnight. The Bartholomew stopped working, and I went on to carbo for 6 months. That didn't work at all. So I'm now on nivolumab. I've not got any side effects whatsoever. I was terrified of starting immunotherapy because I'd heard so much about it, and I've never felt so good. I've never looked so good, but I don't know if it's working. I've got a scan next Friday and I'll find out then. So up until then, I'm kind of in limbo, but I say I've not got one side effect at all. And yet you hear people having all different side effects. I've been on it since August, so maybe I'm just one of the lucky ones that's just not getting side effects.
That's true. There's been a big difference for you, hasn't it, since you've been on in the Volumab? You felt, you look well, you feel well.
When I was on the TKIs, my hair turned, all my body hair turned white. As soon as I went on to the immunotherapy, my natural colour grew in.
Right.
Even now, I mean, I went to Raigmore in Inverness a month ago. My consultant didn't recognise me because my hair had grown in and I looked healthy, if you want to put it like that, because obviously on the TKIs, it strips your pigment, so you look pale, your hair's white, so that kind of interferes in that respect as well. Whereas with this immunotherapy that I'm on, I mean, I look great and I feel great, but as I say, it's inside it counts, isn't it, as well?
It's really, really important. No, thank you for sharing that. I do remember all the different colours of hair that you were doing at the time as well, swapping photos of our hair colours. No, that's fantastic. So this is an interactive. Does anybody get anything to add? Any hints and tips that they've got? If you pop it in the chat box, you know, related to fatigue or hand and foot, sore mouth, blood pressure, diarrhea. Someone said that they're on Bartholomew and now use lactose-free milk, which has helped them a lot with their upset stomach. Someone earlier had said they had a blood pressure app on their phone, which was easier for them to record it rather than putting it in paper.
I had never heard of the blood pressure app, so I'm going to look at that, because I've got a monitor at home anyway. Until you find your monitor and your piece of paper and your pen, your blood pressure's through the roof. So if it's on the phone to use as an app, I think that would be quite good. So I'm going to look at that and see.
I think that's a really good idea. Yeah. So I've not got any other hints and tips there at all. I think we've covered quite a lot today, and it's been quite a long webinar session. So what I'd like to do is thank everyone who's taken part. Ellie, Darren and Jenny at this latter part, sharing your stories, because the feedback's great. Just briefly there, someone's mentioned that folic acid has helped with their mouth as well. I've heard that before too. And of course, a big thank you to the team at St Bart's in London, the uro-oncology team. Thank you very much for taking time out of your day to come and share this really important role of the clinical nurse specialist, and reassuring people. I think it's really important, reassuring people about these side effects can be manageable, or indeed who to contact, and not to just sit in a side effect, to really get in touch. Does any of the team have anything to add before we close?
I was just going to say thank you very much to the patients for their experience, because that's invaluable. And you might think that this session is just us talking to you, and it really isn't, because what you tell us is real life, and we're looking at a lot of quality of life data. And then the other thing that I was just going to say is, what's the problem with the white hair, dudes? Thanks again.
Bartholomew, that's brilliant. Yeah.
Mine went so white. I looked like I was morphing from Jeremy Corbyn into Father Christmas, and it literally was over. It literally was over December. It was hilarious. I kind of really liked it. I changed my whole wardrobe to look Scandinavian, and then it changed back in 3 weeks later. So yeah, it was short-lived, but it was fun.
It's sometimes just looking at the
hair. I'm just waiting for mine to go fully white as well. So because I'm just waiting. So I love it. Yes.
It looks very cool. Thank you, Jennifer. It's cool.
No, that's fantastic. So thank you very much. I'm just going to share my screen again just now. So just a reminder, really, that the support network is there for you. It can be family, medical team, those of us in the third sector. Friends, of course, are really important, work colleagues, social connections and family, as well as your clinical nurse specialist team. And at Kidney Cancer UK, we do have these wonderful coffee, cake and chats. So for people who are at the metastatic part of their journey, we meet up every fourth Wednesday of the month at 2 p.m. Just look out on the Facebook page or the website to find out about it. We have our own wee groups in Scotland as well, but we've got quite an established, and we're hoping to start something in Northern Ireland too. We also have groups for people, for partners and carers, and those who have just had surgery too. Just a gentle reminder as well, we are here to listen, inform and support. We have our care line, and we have our counselling too. Thank you very much, everybody.
Yay.
Okay,
Thank
take
you.
care. We're going to stop recording now.
Thank you.
Thanks so much. Bye-bye.
Thanks very much.
Bye-bye.
Bye.